Welcome back to Discussions with Dr. G. Today's discussion is about the cell wall warriors, where we get to nerd out about antibiotics that basically act like demolition crews for bacteria. I'm Dr. G, and today we're talking about why these drugs are so darn good at what they do and why, thankfully, they don't just nuke our own cells in the process. So let's start with the basics. Peptidoglycan. I know, it sounds like a breakfast cereal, but it's actually the stuff that makes up bacterial cell walls. Humans, we don't have it, not even a sprinkle. That's the whole trick. These antibiotics are like heat-seeking missiles for peptidoglycan, so they go after bacteria and leave our cells alone. Selective toxicity, that's the fancy term. It's like if you're allergic to cats, but you only go to dog parks, you're safe, right? Well, unless there's a rogue cat, but you get the idea. Picture a fortress made out of sugar cubes in a rainstorm. That's a bacterial cell wall, and our antibiotics, they're the rain. Bacteria just didn't think this through. Humans, on the other hand, were more like, brick houses. Not a perfect analogy, but you get the point. So that's why these drugs are so powerful and why, for the most part, they're safe for us. But of course, nothing in pharmacology is ever that simple. Let's get into the heavy hitters. First up, penicillins, the OG wall smashers. Penicillin G, amoxicillin, piperacillin tazobactam. You know the drill. These are great for gram-positive cocci, like strep throat, and some of the extended spectrum ones can even take on gram-negatives. Piperacillin tazobactam, that's your big gun for Pseudomonas. But here's the catch. Allergies. Penicillin allergies are like the peanut allergies of the antibiotic world. You gotta ask every single time. Rash, hives, full-on anaphylaxis. It runs the gamut. And don't forget the GI upset, nausea, diarrhea, and my personal favorite, the risk of C. diff. Because nothing says, I'm a nurse, like cleaning up after a patient with toxic megacolon. Oh, and if your patient's on oral contraceptives, you better warn them. Penicillins can make those less effective. Double up, folks. And warfarin? Watch for increased bleeding. You might end up with a patient who develops a rash after starting amoxicillin. They may even start freaking out, thinking it's anaphylaxis, but it's just a mild rash. Still, you have to take it seriously. Always ask yourself, is it just a rash or do you need an EpiPen? That's the big difference. Moving on. Cephalosporins. These are like the penicillin cousins who went to med school and just keep specializing. First 5 generations, okay, each one is a little fancier than the last. First generation, like cefazolin, great for surgical prophylaxis. Third generation, ceftriaxone, is your go-to for pneumonia and meningitis. And cefepime, the 4th generation, is for those nasty hospital infections, but again, allergies. There is a cross-allergy risk with penicillins. Like I said, these are the penicillin cousins. There's about a 1 to 3% risk. Not huge, but not zero. And some cephalosporins mess with vitamin K, so bleeding risk goes up, especially with warfarin. Oh, and don't let your patient drink alcohol with certain cephalosporins like cefotetin unless you want to see some violent vomiting. Carbapenems. These are your broad-spectrum brutes. Imipenem, cilastatin, meropenem. These are reserved for when your bacteria are basically laughing at everything else you've thrown at them. Super broad, but not without risks. Seizures, especially if your patient has renal impairment or is on a high dose. And of course, superinfection is a risk. You do not give these lightly. And then there's vancomycin, the last resort bulldozer. MRSA, endocarditis, osteomyelitis. This is your SWAT team, but you've got to respect it. Nephrotoxicity, ototoxicity, and the infamous red man syndrome if you infuse it too fast. It's not a true allergy, by the way. It's just your patient turning into a tomato because you were in a hurry. Slow and steady wins the race with Vanc. So let's talk safety, because that's where things get real. Cross allergies. Always check for a penicillin allergy before you give a cephalosporin. It's not a hard stop, but you need to be cautious. And don't forget about drug interactions. Oral contraceptives, warfarin, alcohol. These can all get messy with cell wall antibiotics. And then there's C. diff. Any broad spectrum antibiotic can set the stage for a C. diff party. And trust me, nobody wants to invite that. Nursing interventions are huge. Infusion rates, especially with vancomycin. You've got to go slow, at least 60 minutes, or you'll be explaining to your preceptor why your patient looks like a lobster. Trough levels. Don't skip them, or you could end up with a patient with borderline nephrotoxicity. Not fun. You have to monitor BUN, creatinine, and make sure you're not pushing those kidneys over the edge. And patient education. This is where you earn your gold star. Make sure you know and they know to finish the whole course, even if they feel better. Teach them the signs of C. diff: extremely stinky, watery diarrhea, abdominal pain, and fever. And if they're on vancomycin, tell them to report any hearing changes or ringing in the ears. All right, that's a wrap for today's episode. Remember, bacteria build walls, but we build better weapons. Just use them wisely, because superbugs, they're always watching. We'll dig into even more antibiotic adventures next time. Until then, keep those trough levels checked and your infusion pumps slow. See you soon.